Good morning, colleagues, and welcome to PeerView Live, A New Era in Treating Advanced Ovarian Cancer, Practical Tips for Maximizing the Use of PARP Inhibitors, Immunotherapy, and Antibody-drug conjugates. I'm Dr. Kathleen Moore, and I'll introduce my panel in just right now. So I'm from the University of Oklahoma. I'm very happy to moderate this session this morning, and I'm joined by two of my good friends and colleagues, Drs. David O'Malley from The Ohio State University and Dr. Bhavana Pothuri from NYU Langone. Welcome to my colleagues. We just lost Dave, but he'll be back. Thank you to PeerView and the Foundation for Women's Cancer for providing this session, and to our sponsors, AstraZeneca, Merck, and Sutro Biopharma, for providing these educational grants for this symposium. There's a pre-event survey if you wouldn't mind filling that out. And I'll call this out throughout the session, but there'll be little opportunities to do polling that we'd really encourage you to participate in from your phone. You can also, and for our online audience, you can put, there's a QR code that hopefully you already have downloaded, and you can send me questions up here on this tablet, or you can stand up to the rotating microphones. So we do encourage questions. We're probably going to be pressed for time, so we'll get to as many of them as we can, but please go ahead and submit them. And again, for my in-room learners, your personal device can scan the QR code on this slide. Almost. There we go. So you can send in questions and do our polls, etc. And then this is the kind of website you can go to view the slides and the practice aids, and you can download these all after the event. So this material will be available to you after our event today. So our goals for today are to kind of recap, and I'm going to do it very shortly or efficiently, the data around PARP inhibitor use. We're going to spend a little bit of time talking about the frontline data and checkpoint inhibitors, and then really my colleagues are going to spend quite a bit of time taking us through our emerging favorite new medicine, which are antibody-drug conjugates, and where they fit into the treatment paradigm in ovarian cancer, how we integrate these new, I guess I would call them modern targeted therapies into individualizing care plans for our patients, and then really focus throughout on team-based multidisciplinary strategies to optimize not only efficacy for our patients, but also tolerance and very high patient-centered quality of life. Again, we have a partnership with the Foundation for Women's Cancer, which we know and love. This is a very important partnership, not only for SGO, but for our patients. As you can see, there's tools that are free for providers, so physicians, APPs, and also our patients to download online that cover all of the gynecologic cancers, including ovarian cancer, with a mission of public awareness for everyone, but really advocacy for our patients. So thank you to the Foundation for Women's Cancer. You should see a little polling question on your device, so please answer this poll about your challenges in treatment decision-making in ovarian cancer as we move into the first section, which is me. So we're going to talk about PARP inhibitors. I think I've been showing this slide now ever since Dr. Constantinopoulos published it, so it's been a decade. Woo, I'm aging myself. But I've been showing this slide for a long time. But this is really what one of the several discoveries that launched the interest in targeting DNA damage response in the first place, this understanding of the molecular landscape of ovarian cancer. Again, there's many youngins in the room, but I see some of you that are about as old as Dave and I. So we remember a time when you just said, I have epithelial ovarian cancer, and you get paclitaxel and carboplatin, and that's about all you thought. Like, there wasn't any testing for BRCA. We were not sending the tumor for any sort of analysis. You were just using chemotherapy kind of uninformed. How that has changed, and you're going to hear today how it's continued to change. So this data really opened our eyes to the fact that all ovarian cancer isn't ovarian cancer, and there are subsets that may benefit more from targeting DNA damage response. And you can see that here, just to reiterate, about 50% of high-grade serous, and we can probably include high-grade endometrioid, have some sort of vulnerability inherent to themselves that makes it hard for them to fix their DNA. The most common vulnerability, of course, is BRCA, RAD51C. There's epigenetic changes. We now understand 10% of tumors may have BRCA1 promoter methylation or even RAD51C promoter methylation. All of these make them vulnerable to DNA damage, blockade, and susceptible to PARP inhibitors. But as we've also discovered, it's not yes or no. These tumors that apparently are good at fixing their DNA, we still see some benefit from PARP inhibitors. So this information, while very helpful in launching the PARP era, wasn't quite perfect enough to help us really discern who should and shouldn't get a PARP, and we'll talk about that. We have 3 studies, 2 PARP inhibitors, FDA approved in Frontline. We still don't, unfortunately, have an approval for rucaparib, but we have niraparib approved as switch maintenance, as I was just saying, for all comers, based on the data of PRIMA. So while there is a gradation in benefit, there was benefit in all subgroups, which is why we have an approval across molecular subtypes for niraparib. Olaparib, a little bit different for monotherapy because of how the studies were designed, SOLO-1 and PAOLA. The benefit here was really in the BRCA and HRD test positive population. So monotherapy olaparib only has an indication in BRCA-associated cancers. Olaparib and bevacizumab, based on the PAOLA data, an approval in HRD positive, inclusive of BRCA, but not inclusive of HRD negative. So this is kind of the current landscape in the Frontline with regards to PARP inhibitor maintenance. There's so much data, I'm just going to show you the overall survival data, because here we are talking about overall survival. Again, I remember a time when we were and we still do fight for PFS. We believe in progression-free survival. It's a good endpoint in clinical trials, but also as a meaningful goal for our patients, too. A meaningful improvement in progression-free survival does benefit patients. But some of our focus on that was because of the long post-progression survival. In ovarian cancer, we all kind of thought we would never really impact overall survival. So we kind of had said, well, we're just going to really focus on PFS. So the gauntlet has now been thrown. We have shown that we can impact overall survival, and so that is re-emerging as a focus as we bring new medications into this space, and you'll hear some about that in a moment when we talk about immunotherapy. So here is the overall survival for SOLO-1. This was presented by Paul D. Silvestro at ESMO a few years back, and this was an interim analysis, pre-planned at 7 years. You will be hearing updated data somewhat soon. So there was very little alpha allocated to this analysis, so it's statistically not significant, but come on. This is different. These patients are different doing well. So there's p-values and there's reality. So this is overall survival. But it's just amazing to me that we're talking about this is overall survival, but this is disease-free overall survival here. So these are cures, which again, we just weren't using that word, and now we are. So these are likely patients who are cured. This is updated progression-free survival at 7 years, and we'll update this again, hopefully, when we do the final analysis on SOLO-1. But at 7 years, we have 45% of patients who haven't recurred. So they finished their PARP inhibitor 5 years prior to this, and they still haven't recurred, versus 20% in the placebo group. So that's kind of our cure fraction without PARP. So there is a cure fraction without PARP, and if we could identify them, we could de-escalate, and that would be amazing. We can't do that yet, so we are over-treating, admittedly, that 20% to rescue an additional 25%, and now we need to focus on rescuing the other 55% who do recur. But we do not only have evidence for improved overall survival, but we do have a signal that we are curing patients, and we have disease-free survival as well. And we saw evidence of this with PAOLA as well, which had a broader population. The HRD test positive cohort in PAOLA was substantially populated with BRCA, but about 20% were BRCA wild type HRD positive. And I'm just showing you the overall survival by subgroup here. There's a similar disease-free survival analysis at 5 years for that HRD positive group that looks very similar to the 5-year mark at SOLO. This is overall survival in BRCA on the left, HRD positive, BRCA wild type in the middle, and then HRD test negative, which of course was negative for PFS as well. And you can see there are clear trends. It's not overwhelming improvement in overall survival outside of BRCA, but there are trends that we are moving the needle here, which I think is quite important for our patients. We've not ever done that. These curves usually just are right on top of each other. So this is exciting. And then we saw overall survival data from PRIMA last fall, which was something many of us were kind of anxious to see because it was such a high risk, clinically high risk population of patients, and we wondered whether or not this would look different outside of maybe a less high clinically risk. There's no such thing as low risk ovary cancer. I always like to say that, but there are certainly gradations of high risk, and SOLO and PAOLA were not really clinically the highest risk tumors. PRIMA was stage 4, all neoadjuvant mostly. So we were kind of wondering whether or not the trends would hold. And also, the times have changed. You know, there's way more crossover at the time of progression to PARP on PRIMA than there ever was on SOLO 1 and PAOLA. And so the kind of post-progression survival changed over time, and we wondered how that would impact here. And so this is PRIMA overall survival, which they're kind of right on top of one another, which is honestly a relief to many of us that we didn't see the curves invert. So this is reassuring that even in the highest risk population of patients who are going to get post-progression effective therapies, we're not seeing a detriment to overall survival. So you can now do a little polling question, just as a reminder. But let's move on to, so that's PARP, and we've been talking about PARP inhibitors for a long time. Let's talk about what's new. And you're going to hear at this meeting, I think today, Keelink is today, yeah. But Keelink was presented. So let's talk about checkpoint inhibitors, because this is really the data we've all had boxes up on every slideshow for like 3 years, like these are coming. Well, now they're here. So we can talk about them. 4 studies, all incorporating an immune checkpoint inhibitor with a PARP inhibitor. So the thing I want to emphasize, and I don't have a ton of time, but I'll try to emphasize this as I go through. Even though these are 4 studies, all with a PARP inhibitor, all with an immune checkpoint inhibitor, some of them have bevacizumab, they're all very different in terms of their design, statistical analysis, eligibility. And so they're probably more different than they are similar, and I'll try and make those points as we go through. So Athena combo. Athena combo, I'll remind you, was randomized phase 3 study. It's a switch maintenance study. So it's the most different of the other 3 because patients weren't enrolled until after they were done with chemotherapy. So they had to respond to their chemotherapy, and then they were enrolled, kind of like the PARP inhibitor studies were done originally. The control arm was a PARP inhibitor, so I like that. So it had rucaparib. And the experimental arm was rucaparib plus nivolumab. And that was the question, a very clean question stratified by homologous recombination deficiency. In this case, it was LOI. So, or LOH, sorry. So very clean study. And we were anxiously awaiting it, and these are the results. And we were all a little stunned to see this. But it's probably real. So the curves are not in the right order, if you'll notice. The PARP arm alone is orange, and the PARP plus nivolumab is in blue. And so you'll notice that blue line is below the orange line. And you'll notice the hazard ratio is above 1, and that confidence interval is entirely over 1, which suggests harm. So you gotta let that sink in a little bit. What the heck happened here? That was not what we were expecting. That's not why we do clinical trials. We don't seek to harm patients. But they did not benefit from this combination. And you can see the overall survival, which is premature on the bottom. But again, it's mostly right on top of each other, but that blue line is not on the right side. So there's absolutely no difference in PFS or OS clearly. the inclusion of checkpoint inhibitor did appear to worsen outcomes. And I don't have time to show you the subgroups in the forest plots, but every forest plot favored rucaparib alone. There wasn't a single subgroup where you went, maybe, no. Everything happened in the wrong direction, which takes us to the question of why. And this is something maybe we can chat about. But one thing I was thinking about is this idea of dose optimization, which is, we talk about this a lot as a regulatory requirement, and sometimes we're like, we have to dose optimize. But it's actually really important to understand which dose is most effective and least toxic for our patients. And also, combinations can have surprising problems. And is that the only thing that happened here? Probably not. But the question is, was this combination that we all thought would be easy peasy, was this optimized? Because the patients on the combination arm discontinued due to reasons other than progression far more often than the rucaparib alone arm. And when they discontinued both drugs. So drugs don't work if we don't take them. And so is that, if patients just quit both maintenance medications for an AE of some sort, is that what caused the curves to flip versus the group that could continue what is known to be an effective PARP inhibitor? That's a hypothesis. I think we'll be talking about this for a while. But honestly, a troubling result, and made us all, those of us that are leading some of these other studies, a little nervous to see the rest of them. So then Duo-O. Duo-O we saw actually before Athena. Duo-O is similar to the other three in that patients were randomized from the beginning of their chemotherapy. So it includes the time on chemo. It's chemo alone with no maintenance, plus minus bevacizumab. So they could have bevacizumab maintenance. I'm sorry, this one is all bevacizumab. Sorry. So bevacizumab maintenance, chemo bevacizumab, bevacizumab plus durva, chemo bevacizumab, durva, bevacizumab, durva, olaparib, so triplet maintenance. All in BRCA wild type. So there's no BRCA mutated tumors in this cohort. There's a separate sort of exploratory cohort, but this is all BRCA wild type. And what do we find? Well, it looks positive. Arm 3, which is the triplet PARP, Bev, immunotherapy versus Bev, wins. So statistically and as designed, this is positive. Okay, I believe that, but I want to know what the PARP, Bev alone arm would have done. Like, what's the importance of the durva here? I don't know that I really, know. And then here is the HRD positive. So that was the ITT. This is just pulling out the HRD positive, which again, this is statistically positive and as designed a positive trial with a great hazard ratio of 0.49, PARP, Bev, immunotherapy versus Bev, which wouldn't be my standard of care for an HRD positive, even BRCA wild type tumor. So I guess I don't quite still know how to interpret this, for my patients. And I was hopeful to see, get some answers from KeyLink. And you're going to see KeyLink today, presented by Dr. Matt Powell. It was presented, and so is in public domain from ESGO a few weeks ago, so I can talk about it. So KeyLink is different than Duo-O. It's also BRCA wild type, 3 arms, carboplatin, paclitaxel, placebo with or without bevacizumab, carbopaclitaxel, pembro maintenance, carbopaclitaxel, pembro, olaparib maintenance, all with or without bevacizumab, all BRCA wild type. So you may say, well, that's just like Duo-O. It's similar, but here the stratification factor is PD-L1 status, greater than or less than 10%. And in Duo-O, it was HRD. So it's a different stratification factor, and the primary endpoint is all based on the immunotherapy biomarker. And so they were also similarly looking at arm 3, which is that triplet arm, versus arm 1, which is either no maintenance or bevacizumab. And here, as based on the statistical analysis, arm 3 versus 1, this is positive. So it is positive. It's a positive trial with a great hazard ratio. But my question again is, what does this mean with no monotherapy PARP arm? I don't really know how to interpret this in this population. And there's no benefit when you see, when we've known this for so long with bevacizumab alone. This is bevacizumab pembro, or just pembro versus the control arm, which could have bevacizumab or not. We've known this from my study, Imagine 50. We've known this from Javelin, that immune checkpoint inhibitors alone don't work. This reinforces that. So my question really, and I'm going to ask my colleagues in a second, is, how do you interpret this? I don't know what to make of this. So statistically positive, but difficult for me to clinically interpret, and no benefit in overall survival, which is, I think, an increasingly important endpoint if we're going to give people 3 medications. We're going to talk about adverse events a little bit as we go through here, but we have common adverse events with PARP inhibitors. We know these well. I don't know that I need to belabor that with this group, but we do have to continue to be vigilant about managing adverse events. And so let's just kind of put all this into a case, because you're all going to go home on Tuesday and have all this data and have to make a decision. So this is a patient made up from patients that I see at home, presents with advanced disease, markedly elevated CA-125, pleural effusions, ascites, just kind of stage 4A high-grade serous ovarian cancer on biopsy, BRCA wild type, HRD positive. She's folate receptor alpha high, because we sent that panel, and she's HER2 2+. And she's here for her post-biopsy counseling with my colleagues and wondering how the heck you're going to plan her therapy. What are you thinking about for her? ADCs aren't here quite yet, but how are you thinking about her, Dr. O'Malley?
Well, I mean, we have disease above the diaphragm, pleural effusions. We all know that operating on these in a primary debulk, and these patients have a lot of challenges. So my first decision is, am I going to do neoadjuvant or primary debulk? And I think in this patient with ascites, large volume ascites, more importantly, pleural effusions, I'm going to talk to her about neoadjuvant chemotherapy. Next decision I'm going to make is Bev, no Bev. I think with the pleural effusions, with the ascites, the other thing we didn't really talk about is, do we stick a scope in, get some tissue? We already have the biopsy in this, so we already kind of done that. So in this particular patient, I'm going to add Bev. And if I have the HRD positive, depending on what she does through her surgery, I usually give 3 to 4 cycles before, holding the Bev before. And then as we get this, the decision, and she's HRD positive, for me, this is a slam dunk. You saw the Apollo 1 data. I'm adding a PARP once she's done with her 6 to 8 cycles of chemotherapy to the Bev. So for me, this has become a very straightforward question. Give Bev, add PARP with the HRD positive.
Dr. Pothuri, we've heard now Duo and Keylink. Are you going to add, they're 2 positive studies. They are positive. Are you going to add, what's your take on the immune checkpoint inhibitor role here? Say you weren't going to use bevacizumab, or you are. Are you convinced? What's your thought there?
Yeah, I think, while those studies are positive based on the way they were designed, I think it's very difficult to interpret them, as you said. And without FDA approval, I think, it's hard to utilize these agents. And I'm not convinced that we're actually benefiting our patients with the addition of IO in ovarian cancer. I agree with Dave's management plan. And I just, I think in this, arena of targeted therapy, I think it's really important to get that tissue. So if you can't get a good core, I think take them to the OR, get tissue so that you can assess your biomarkers, because many patients will not have any disease at the time of interval debulking. And I would do pretty much exactly what Dave said. However, if I had a trial for this HRD patient, I would consider a clinical trial, especially with their biomarkers.
Especially if the HRD negative. I think that's the more interesting discussion. I'm
exactly.
not sure we have time.
No, you'll get to, you can bring it up in your talk, actually. So before we move to I want to try and get some of the questions. I do see the PARP after PARP question, and we'll come to that in the recurrent session. But Dr. Pothuri, you just brought up the importance of tissue and getting a good block, and someone had just asked when we send all this testing I just said. Clearly, I sent it in the front line because I made this case up. But when do you send testing for germline somatic, and are you ever retesting? Can you comment on that briefly, and then we'll move to Dr. O'Malley.
Yeah, so we send everything up front. We send germline, somatic testing. We even check for FR alpha and HER2 at the initial diagnosis. And if they do have biomarkers, we utilize those in their treatment in their recurrent setting. If they are negative, then I will often send another sample from a different disease site to reassess. And if that's still negative, I will rebiopsy.
Okay, great. I think we can talk about that a little bit more as we go. Just another, again, call out to the free online resources that FWC provides, just so many tools, just to make sure everyone is aware that those are available for your patients, so you can download them. And a little reminder to do the poll that should have just popped up on your phone. And I'm going to turn it over to Dr. O'Malley.
Thank you, Katie, and thank you for everybody. I'm trying to think, like, what percentage here are East Coasters versus West Coasters? You're like, this is late in the day for an East Coaster.
I know.
So
We're awake.
appreciate y'all being here so early this morning. And great to see everybody at the alumni events, the DI event last night, as well as I think the international, which I didn't have a chance to attend. So seeing our society engaged and moving forward is so important. My clicker is not working.
Oh, no.
There we go. So, we just tested folate receptor alpha. We had a positive. I really want to see what it's not just positive, but what the percentage are. And we're going to talk a little bit about that. So the positive is the high folate receptor expression 2+ greater than 75%. But for us, and please, when you put these in your chart, positive rates may change over time, is put in your chart the percentage, as well as HER2. We've had to go back and look at a number of patients who had negative HER2 testing to see what they really are. And why am I saying that? Because like Bhavna, I test folate receptor alpha and HER2 upon diagnosis. And why is that? Because I want to know what my options are in the future. We know that MERV is an ADC. We've heard a lot about that. And again, for this group, it's not as important to talk about what makes up and how the ADC works. But I do think we need to think about payloads now. Payloads in DM4, an anti-microtubulin, a paclitaxel-like mechanism of action, is very important as we talk about the topoisomerase payloads. And we're really talking about very different agents here. I'm amazed at how often I get that question, that for me, a topoisomerase 1 payload is a completely different drug, and I think hopefully for all of you, than an anti-microtubulin. So when we look here at the 10 years, I owe so much to Katie Moore, and one of the things I'm so appreciative of is her making an introduction to that time Immunogen in their first in-human trial over 10 years ago. And we participated in that trial and have walked together throughout this pathway of this ADC in ovarian cancer, with the accelerated approval first in 2022 and full approval in 2024 based on the MIRASOL data. The accelerated approval is actually based on SORAYA, which is a single-arm registration trial, which showed a 32% response rate. But to remind people, MIRASOL was a repeat of Forward 1, and what were some of the lessons? We limited to high folate receptor alpha. We limited it to 2+ testing. And then in a 1-to-1 randomization, we tested 453 patients to MERV versus investigator choice, which include weekly paclitaxel, pegloticosome, doxorubicin, or topotecan. And you had to declare that before randomization, and was one of the stratification factors. And what did we show? A fairly modest progression-free survival. And if we're only talking progression-free survivals, and this is the problem with medians in platinum-resistant ovarian cancer patients, the hazard ratio is 0.6 to 35% improvement, but look at the medians, 4 versus 5.6. If I just showed you that, you'd be, it's a month and a half. Medians are very difficult to discuss in platinum resistance. So many are sensitive at the first or second disease assessment. You have to look at separation of the curves. You had 35% improvement. But why was the drop the mic when Dr. Moore presented this data? Survival. For the first time ever in platinum-resistant ovarian cancer, we showed overall survival advantage. Hazard ratio 0.67. We maintained our PFS in OS. Medians, almost 4 months. Okay? But look at those tails of the curve, and all of us who've treated MERV have those patients, those long-term responders. those walking miracle patients with platinum-resistant ovarian cancer. So we see this marked improvement. And how about if you need a patient to get a response? 16%, unbelievably consistent in our investigator choice, 15% plus or minus. And we know weekly paclitaxel is 30%, so try to do the calculation of PLD and topo, right? 15% of the entire population versus 42% in MERV. And how about if we combine it? This is work that, based on the original Forward 1, we had to kind of change gears here, but looking at MERV plus BEV. So this is a conglomeration of all of our 130 patients, not quite, 126 to be precise. And what we found was, we saw when we combined activity across all low, medium, and high expressors. And we looked at the overall response rate in the entire population of 44%, the overall response rate in the platinum-resistant, all comers, remember low, medium, and high, 44%. And we look at the difference here, we've learned this over time. We were unclear when we first started, but high folate receptor alpha seems to be higher duration of response, deeper response. But we see benefit across this, and we'll talk a little bit about that in TDXD. But what's interesting, the platinum sensitive, we saw about a 48% response rate, again, across all of these patients. We don't have time to go into all the subsets. But interesting, Angeles Alvarez-Secor presented Piccolo last year and took a unique patient population in that platinum sensitive space, at least two prior therapies, platinum sensitive, that'd be candidates for single agent treatment. We all have those patients. Hematologically, they're beat up by carboplatin, we're really having trouble getting the platinum in, or they've had a hypersensitivity that we can't desensitize. So we actually looked at, in this group of patients, and found a 52% response rate, single agent MERV, who were candidates for patients with not giving platinum doublets. Now, how does that compare? Pretty similar to the platinum doublets and platinum sensitive, but again, a patient who you don't think is a candidate for retreatment with platinum, this is an option with, again, 52% response rate. This data and the MERV-BEV data led us to now the ongoing Gloriosa study. For those who have it open in the room, please continue to enroll this. It's enrolling well, and we're looking forward on clinicaltrials.gov. And they publicly said we're expecting that to be enrolled by the end of this calendar year. But it's patients who have gotten BEV in the first line platinum sensitive, so second line, who have a high folate receptor alpha, okay? In that patients, they're then randomized to BEV versus MERV-BEV. So very important for us to see, can we have access and can we deliver these ADCs in a maintenance-like setting? You could argue this is a sequence question. Okay, as we move forward. And this comes with somewhat of a price. We say, oh, ADCs, they're not chemotherapy. They are chemotherapy, guys. They're directed, they're smarter, but they are chemotherapy. Hematologic, actually MERV is quite well tolerated when you compare it to the physician choice chemotherapy. Peripheral neuropathy, you will see cumulative toxicity, the antimicrotubulin of MERV. When we looked at the MERV data, we did see a continuation rate based on neuropathy, but that usually was somewhere between cycle 13 to 14. So interrupt, dose reduce, and don't let it get to the point where you have to discontinue therapy. GI, a little bit more on diarrhea. It's interesting when you look at the paclitaxel, also in GI. I don't really think of diarrhea as a side effect of paclitaxel, but when you look at it, we see it both in the MERV and weekly paclitaxel. And obviously, we've known much about the ocular toxicity, and we could do an entire 10-minute talk just on that. But let's switch gears a little bit and talk about this next generation. We're looking forward to hearing Bhavna's discussion about all of the upcoming trials. Now, we have the agnostic approval for TDXD and 3+ IHC. And we look across our diseases. This is the lighter blue is amplification. The darker blue is overexpression, so that's your IHC. And the purplish is the mutation. So those percentages that we see and outlined in the red are those three different ways. So we see the overexpression and amplification are definitely higher and actually a very low mutation rate. But how do we test? I now, when I send my tissue, say, please use the gastric criteria. Please use the gastric criteria. At least I could compare that apples to apples. I've already highlighted the difference in TDXD versus MERV, which is the payload, and obviously the target, folate receptor alpha versus HER2. But this is a topo-1 inhibitor, okay? This is another DNA targeted type therapy. So we think of antimicrotucan paclitaxel, obviously topo-1 like topo, maybe more similar to platinums, but not quite an alkylating agent. And we're looking specifically at the pan-tumor 02, or the Destiny pan-tumor trial, excuse me. And we're looking specifically at the ovarian cancer cohort at TDXD at 5.4 milligrams, heavily pretreated population. Locally, they had to have 2 and 3 plus. Locally, they had to have 2 and 3 plus, 2 or 3 plus IHC. And then it was reviewed centrally. So when it was reviewed centrally, and we look at the occurrence, and we've all seen the 2 and 3 plus data, which led to the NCCN listing of 2 and 3 plus. But every time I looked at that data, I said, wait a second, and I talked to Evelyn, my 7th grader, and I said, Evelyn, help me with the algebra here. And Evelyn helped me with the algebra, and I said, wait a second, the 0 and 1 pluses are exactly the same as the all, so we need to see the data on the 0 and 1 pluses. Presented by Dr. Lee at last year's International Journal. And here it is. Again, let's take this. TDXD is a nice drug, right? But let's look at the numbers. The entire population, 40 patients. 3 plus 11 patients. 2 plus 19. 1 plus 5, 0, 5. We're seeing response rates across different expression levels. Across different expression levels. Now, am I advocating to use TDXD in a score of 0? No, I'm not. But we have to put this in context. In putting this in context, we have to, at this point, make sure we're testing. The agnostic approval, accelerated approval, is 3 plus, and we need to confirm those findings. And how are we going to confirm those findings? Phase 3 trials. So we have this in ovarian cancer. The reason I showed the data was going to both be thought-provoking in the 1 and 2 plus, but because in the Destiny Ovarian 01 trial, where we're looking at TDXD with Bev versus Bev, but this is in first line, Gloriosa's in the platinum-sensitive space, and we're going to use the gastric criteria and include 1, 2, and 3 pluses. And you see, based on Pan-Destiny 02, we have justification in small numbers. We can talk all day, and we'll talk a little bit later in the day with regards to the breast cancer literature looking at these low expressors. Patients complete their carboplatin doublet, and then we'll randomize them in a non-BRCA patient population to TDXD Bev versus Bev, so an active comparator in this group of patients. And for me, this is really that HRD test negative group. TDXD is, once again, these are chemotherapies. They are chemotherapies that are smarter. The discontinuation rate about 6%, okay? Dose reductions, about 30%, about. GI, nausea, diarrhea, okay? Decrease in appetite, even vomiting. Fatigue and hematologic. But what's the rare but serious? ILD. Interstitial lung disease and pneumonitis is clearly something we all need to be considering. And why is that? Because people can die. You look across the paradigm of ILD, and you actually see about 2% grade 5 toxicities. It's probably closer to 1.5 with our current experience, plus or minus a half. And this is a great paper by Powell. I would encourage you all to look at this. This is really, there's some great data coming out. It's really educating us. We're educating each other, right? But when you look at the occurrence, by 7th, 8th cycle, I'm lulled into they're doing great. I'm just, hey, great, you know what, your CAT scan looks good, C125 staying down. That's actually the median time of onset of ILD. And what are the other risk factors? Interestingly, age less than 65, if you're from Japan, lung comorbidities, and then go down the bottom of the forest plot on the right, baseline pulse ox of less than 95%. What else do we have to keep in mind? Going back to the middle, renal function, moderate to severe, you have a 2.73 hazard ratio, okay? Keep that in mind on those patients with a creatinine clearance less than 50, okay? Keep a closer eye on them. And time since disease diagnosis, greater than 4 years, to me, is that because of the time from disease diagnosis, or that the multiple therapies they've had, probably taking little insults to their lungs with our other agents. Yeah. So very important to keep this in mind. Our overall occurrence is about 15%, but don't and do everything you can to avoid those grade 5 toxicities by early identification. Please take a moment to answer this next poll question. And as we move forward here, I'm happy to turn it over to Dr. Pothuri, my good friend and colleague.
Great. Thank you, Dave. It's great to be here with you all today, and I will discuss what's next in terms of the ADCs. So I think it's fair to say there are almost 200 or more ADCs that are in evaluation. And, I'll start with FR alpha in ovarian cancer, and we've already heard a lot about MIRV. This is another FR alpha targeting ADC, luveltamab tazevibulin. It also has a microtubule spindle poison, but does have a hemosterolin delivery system. These were initial data that were presented back in 2023 at ASCO, and we saw here an objective response rate of 32% in unselected patients. And then when we actually selected for FR alpha greater than 25%, we saw an objective response rate of 38%, and the disease control rate was 78% in unselected patients. So this led to REFRAME-01, which is the phase 2/3 trial looking at luveltamab tazevibulin. And the first part 1, is the dose optimization portion. And that portion is completed, and the dose has been selected, and it's 5.2 milligrams per kilogram. And Dr. Lee is actually going to be updating us with this data later today, so stay tuned. And now we are recruiting in the part 2, which is the optimized dose of 5.2 versus investigator's choice chemotherapy. And if you have this trial open, please help us enroll so we can have these results to help our patients. In addition, this agent has also been combined with bevacizumab, and these are data showing efficacy that were presented at ESMO this past year. And you can see here, And you can see here on the bottom left that among this small cohort of patients, 17 patients, we see an objective response rate of 35%. Moving on to another FR alpha targeting agent, rinatabart sesutecan, or Rina-S. This is also an FR alpha targeting ADC, as I said, but it has a different payload. It has a topo-1 payload. And you can see here the dose optimization of 100 and 120 that was presented at ESMO this past year. And we see that in the 120 milligrams, we saw a confirmed objective response rate of 50%. And you can see really nicely here this beautiful waterfall plot showing these data. So this dose is actually being carried over and being studied in Rainfall, which is a randomized phase 3 trial in platinum-resistant ovarian cancer. And it is Rina-S randomized to investigator's choice chemotherapy with the primary outcome of PFS. We're planning to enroll 530 patients. So this trial is open, has enrolled 2 patients. So really excited given that 50% objective response rate that we saw in the early studies. So please help us if you have this trial open. The next agent we're going to talk about is agent that targets cadherin 6, which is RDXD. And this too has a topo-1 payload. And Dr. Moore actually presented this data exactly a year ago in the opening session at SGO. And this agent also had very nice efficacy, a confirmed objective response rate of 49% with 1 CR, and a disease control rate of 97%. So almost all patients had some response or stability. And here are the most common adverse events that you can see here. Overall, really well tolerated, some GI side effects, and then counts, anemia and neutropenia, which we would expect with your topo-1 payloads. So this agent is now being studied in a phase 2/3 study called REJOICE Ovarian 01. And this is looking at high-grade serous or endometrioid ovarian cancer, 1 to 3 prior lines, platinum resistant, and if they are FR alpha high, they must have had prior mirvetuximab, and they also cannot have had a topo-1 inhibitor. And so this is, again, the first part of this is a phase 2, which is doing your dose optimization with, in a randomized fashion with 3 different doses. And then that will carry on to the phase 3 at the optimized dose versus physician's choice chemotherapy with the primary endpoint of ORR and PFS by BICR. So we'll now move on to another target, TROP2. And TROP2 is expressed in the majority of ovarian cancers. This is Dato-DXd. This data is from the phase 2 trial, the TROPION-PanTumor, which had an ovarian cohort. This data was presented at ESMO recently, last fall. And you can see here, this was high-grade serous or endometrioid ovarian cancers that progressed on greater than 1 line of platinum chemotherapy. And it had 35 patients treated at 6 milligrams per kilogram with a primary endpoint of ORR. And you can see in the 35 patients that were treated, the confirmed objective response rate was 43%. And they did have 1 PR. And then here are the platinum sensitive and the resistant cohorts. So when you break it down into the 26 patients who had platinum resistant disease, that objective response rate was about 35%. And you see this nice waterfall plot here. In addition, the median duration of response was about 6 months, and the disease control rate at 12 weeks was 80%. Another TROP2 targeting ADC, sacituzumab turmotecan, or SAC-TMT, also has a topo-1 payload. It's a belotecan derivative. This is now being evaluated in the phase 3 setting, Trophus 005. The dose optimization obviously needs to occur, but the plan is for SAC-TMT, and this is the dose optimization which will lead to the phase 3, sorry. This is the data that looked at ovarian cancer that was treated at the 5 milligram per kilogram. And in the 40 patients, you can see here the confirmed objective response rate was 35%. When you break it down and look at the high expressing TROP2s with a H-score of greater than 200, that was 62%. And then in the platinum resistant, it was 37%. And again, with these longer duration of response, and a median PFS of 6 months, which is double that of what you would see with chemotherapy. So these are supporting the phase 3 trial that I alluded to, and you can see the swimmer plot here with some nice long responses. Another TROP2 ADC is DB1305, and this has been evaluated in and presented in a cohort of all tumors that express TROP2, and it noted an objective response rate of 30%. And Dr. Rubenstein is going to be presenting later today the ovarian cohort with DB1305, so stay tuned. I think the thing that's really important with these TROP2 ADCs is oral stomatitis. So those of us who have used these agents know that this is a real toxicity, and we really have to be on top of prophylaxis for these patients. I have had patients who had to get admitted to the hospital for fluids and pain control. It is real. The mucositis is real, and it affects patients on a daily basis because they can't eat or drink. So these patients all should be prophylaxed. So, oral hygiene is really important. In addition, prophylactic steroid mouthwash is important. And then really, in addition to the prophylaxis, the supportive care, once they develop it, is really critical in terms of adding additional medications, really considering cryotherapy during infusion, and then getting your oral surgeon involved as needed, and then, following the dose holds. So I tend to dose hold as soon as I see a grade 2 until it is resolved to a grade 1, because it can progress really quickly to a grade 3. And then really consider, dose holds and then dose reductions as needed. But the key is all these patients should go on prophylaxis. Okay, so if you can answer this polling question, and then I think I'm turning it back over to Katie.
Yeah. So we have a couple cases to discuss, and we also have a few questions. So I'm looking just really quick here. Just answer a question before we move to the case, because it's just germane to what you're just talking about with the management of mucositis. So Dr. O'Malley talked about the screening for and mitigation strategies around pneumonitis and ILD, which we see with the deruxtecan payloads predominantly, but I wouldn't say exclusively. And then certainly we see it with mTOR inhibitors and PARP inhibitors. Like, we see pneumonitis in other places, immune checkpoint inhibitors, but it's really, I think, come to our abrupt attention with the deruxtecan payloads. You just brought us through the mitigation strategies for mucositis, which again, I think many of us are sort of paying attention to intentionally right now because of the TROP2s, but oral mTOR inhibitors, lenvatinib, this has been an ongoing issue. I think we're just finally developing some plans around it. But we had a question from the audience about the care team members that are required now to take care of patients on these new targeted therapies. I think I referenced the multidisciplinary team, so I guess I'm just interested. I'll ask Dr. O'Malley, how are you thinking about the support team for your patients going on this sort of panoply of new medications?
So this is a start, right? Educating the physicians, but we have such an important obligation to educate nurses and our APPs. I tell a story that just within the last few months, I'm embarrassed to admit this, that one of our team took a call on a patient on TDXD actually, and was in cycle 3, 4, and called in with a cough, low-grade fever, and some shortness of breath, and was starting to be told by one of our nurses, you need to go to your primary care. Luckily was overheard because they sit in a whole area, and somebody said, no, we need to get them in. That patient ended up having pneumonitis. So it's a perfect example, oh, you're having diarrhea. We're not telling them to go to their primary care for diarrhea with a chemotherapy associated. So educating your whole team, having multidisciplinary teams, one of the things we talk about, the 5 S's of pneumonitis, right? You have to have a pulmonologist you work closely with. So we have eye toxicity. I hope you've identified ophthalmologist you can go to, pulmonologist. Now we need head and neck or dentistry, which I haven't yet identified. We're just starting to get into these. So we really need to work together to identify those experts who have interest in helping us treat our patients and having them sometimes on speed dial for us for pulmonary specialists, for example.
Yeah, I think I agree 100% with that. We have a kind of an AE response team that's evolved over time, which is amazing in an academic center, but most of our patients are not treated in academic centers. And so if you have a patient with some ground glass opacities on their CT scan who otherwise feels well, and you're in a community practice, finding a pulmonologist who's going to see that patient in a timely period of time, an asymptomatic patient with some fuzzy changes on their CT scan, sometimes it's hard to communicate that is a priority, to get in the next 3 months. I've heard that from some of our partners. So I do, the multidisciplinary care is a necessity, but the operationalization of that was a big word, is I think difficult outside of, it's probably difficult in some academic centers, let's be honest, but I think outside of academic centers, that's a bit daunting to navigate all these professionals who care about your patient, hopefully.
And that's where finding friends, phoning a friend is so important. The other is making sure you're scanning the chest, right? As GY oncologist, I really only used to do abdomen and pelvis unless they had known disease in their chest. Getting disease, making sure we're looking at it. I've looked at more CTs of the chest in the last 6 months than my previous 30 years of my career. Because looking at them, seeing it, because when you read it, you go, ground glass opacities, everybody in the Midwest has some sort of finding on their CT of the chest. Everybody. Talk to my friends in the Northeast. Everybody. Oklahoma. Everybody. So those changes, looking at those yourself is a start, and then asking for help. But it is a challenge. Eye doctors, in some of our underserved areas, it can be a challenge. But make sure you're connecting with us. I know the nurse practitioner on our team has cell phones of other nurse practitioners around Ohio that they're communicating with to talk about symptomatic management. And we can be those people that can bounce ideas off of.
I just want to say one thing.
Yeah, absolutely.
Yeah, I totally agree with that, Dave. And I just want to shout out my nurse practitioner, Kathleen Letts, is sitting right there. And she honestly knows more about mucositis than I do. And I'm really grateful for that. And she makes sure that all the patients, have their prophylaxis, and really having a committed, APP and nursing team who are educated is so key. So, and I think you can develop that, but it is hard. But it's also key as we advance with the new therapies we have and the unique adverse events. And I want to also make one more point about the CT scans in the chest. And really, I think you should also follow them up with those non-contrast scans to really see whether it's pneumonitis or not, because we've been fooled with some of these findings. And then when we actually follow it up, it looks a lot better. So just to get more nuanced information.
Yeah, it's an ongoing education, believe me. So let's do a case, because I have a couple questions about sequencing here, which is, I think, the hot topic that I'm just going to, spoiler alert, we don't know yet how to sequence, but we can talk about it, what we think. But this is a patient, this is standard, very typical patient many of us has. She's in 4th line, platinum-resistant ovarian cancer. She's pretty healthy, baseline grade 2 hypertension. That's because of me giving her bevacizumab, 3 prior lines of cytotoxic chemo, tested like we all are, kind of catching everybody up for HER2 testing, and she's now 3+ by IHC, and I sent her archival tissue. So that's sort of the question. Now she's sitting in front of you. She has tissue from 2020, that's HER2 3+. It's now 2025. This is the person sitting in front of you. Does it matter that the HER2 is from a long time ago? Do you think I need to rebiopsy her? She's never had weekly paclitaxel, by the way. So she doesn't have folate positivity. Should I use that first? How are you thinking about sequencing in this setting? Dr. Pothuri.
So I wouldn't rebiopsy, and I have a biomarker here that's shown significant efficacy. I know it's just a small cohort of 40 patients in the Destiny Pan tumor, but these responses are fast and they're durable and way longer than weekly paclitaxel. So that would be my go-to, would be trastuzumab deruxtecan in this patient. And I also always have weekly paclitaxel that I can follow it up with later.
Yeah, if she comes in and she lives, 2.5 hours away, that's a different question. If she comes in and you see her walking in your clinic and she's walking like this, I love to watch my patients walk down the halls. Because they're like, no, I don't have any neuropathy, but their feet are out here and they're walking slowly. So, in that case, weekly paclitaxel is not where I want to go. She has large volume ascites and really symptomatic. Weekly paclitaxel Bev is a really nice go-to. I'd like to get that Bev on when they have ascites or pleural effusions in the recurrent setting. So this patient didn't, or you didn't say. So, and the other thing is, obviously making sure we have the folate receptor alpha. And again, in the patients, somebody who is 74% versus 75%, this is where that continuing is what the FDA approval is versus we need to use common sense depending on what those options are. So I think those are all the things that come into consideration: performance status, pre-existing neuropathy, ability to get to the center, and how much of a win. But 3+ in TDXD, I've had some really nice wins, and their disease responds usually in the first disease assessment. Yeah. You start to see that PR in that first scan, depending where it is, 6 or 9 weeks.
Yeah, so I've started off a little bit of a softball, right? HER2, we probably use it. So this is more likely because HER2 3+
Thanks
is.
For letting us get warmed up.
Yeah, you get warmed up. HER2 3+ we all want to test, but I think as we test more, we're going to get more firm estimates of the actual prevalence, but it's probably 5 to 7%. 2+ is a little more common, maybe up to 18%, and then 1+ we really have no idea, but it could be as high as 20%. But so this patient's, so it's the same patient, but she's really HER2 2+, non-amplified. She's FR alpha high, so she's 80% 2+. You have clinical trials open, so she has cadherin 6 present. We don't have a level yet, so it's just there. She has TROP2, and she's been sent to your center. You have clinical trials open, and you have MERV. So she's on label for MERV. You have Rina-S available. This is actually a real patient. She doesn't have MERV. So you can give MERV, or you can do Rina-S. Probably going to do both. How do you sequence them? How do you think about it?
I love this question. And one of the reasons I love this question is because these are obviously unanswerable, so we could talk about it all day, but it's 1 to 3 priors. 1 to 3 priors. You have to think of sequencing, getting access to your patients for clinical trials. I say to my patients all the time, without clinical trials, at best I have 5 to 7 tricks up my sleeve, at best. It's really probably 4 to 5, right? But if I can get you on a clinical trial, I can increase that by 2 or 3, 4 tricks. And if we get a win, we're really making a difference on your outcomes, okay? So for me, first thing I think of is clinical trial. Absolutely, because this may be my only chance to get her on a platinum-resistant clinical trial with an ADC. Now, if I had multiple clinical trials and trying to get that patient on, but I can go to MERV in the next line. Yes, I know the label is 1 to 3. Yes, we always get paid. I shouldn't say that. I should probably just jinx myself. But I almost always am able to get it paid beyond 1 to 3 priors. Okay, so I can go to MERV. So I like the idea of a topotecan-1 or a camptothecin-derived ADC. I can go to MERV in my next line, and/or again, clinical trial at 1 to 4 versus 1 to 3 priors. I left for Bobna. I left the TDXD, RTXD, or data. I'm not touching that one.
I'm going to address the MERV. So I don't disagree with that. I don't. What I'm thinking about, and the study we need to do in the Rina-S clinical trial, the phase 1 that Betsy Lee has led, has a post-MIRV cohort. So it's going to be the first opportunity we have for a prospective analysis, like patients who got MIRV and are coming on Rina-S, what's the efficacy? But one of the big missing pieces for us, folate to folate, is the mechanism of resistance. And I wonder if I use Rina-S first and I kill off all the folate high cells, what grows back? If what grows back isn't folate high, will MIRV work? Second line, if I use MIRV first and I kill off the folate high cells, if that's how this works, like we don't really know what grows back, but say only folate low and medium grow back or didn't respond, and Rina-S works in all of them, then PFS1 and PFS2, do I have a longer PFS? I don't know that that's true at all. I just only made that up for all of you. But that's what I'm thinking about just with folate, much less, Bhavana, do I even do MIRV? Do I even do folate, or do I do folate, cadherin 6, TROP2?
Right. I mean, I think we need the studies, and I think it's so important we look at those mechanisms of resistance. And this is an area where I think we probably should be rebiopsying and looking at folate receptor again. And, you know, personally, I like to pick a different target and a different payload, if possible, you know, as my next line. And, you know, just based on some of the, you know, breast data where we see, you know, receptor, decreased receptor, and so I think we have to learn all that, you know. But I think your point is really interesting, right? Like, are we, you know, should we be doing it, you know, should we be doing MIRV first? And I think the study, we have to biopsy and we have to look at this and understand these so we can sequence these better, right? Because we're going to have all these options soon.
Right, we're going to figure it out.
Yeah.
So last question I want to answer, and then we're going to go, because I promised that we would answer this. Let's say she was platinum sensitive, recurrent, and she'd gotten Paula-1 for 2 years, and she's recurred now 2 years later. So she's post-PARP, didn't progress on a PARP, BRCA or HRD, gets your platinum and recurs again. Would you reuse, label notwithstanding, would you reuse a PARP in that setting, yes or no? Like, when would you reuse a PARP, if ever?
If they did not progress on a PARP, looking at the Paula-1 data, if they did not progress on a PARP, I would consider using it based on the OREO data. If they did not progress. If they progressed on a PARP outside of a clinical trial, I am not going back to a PARP.
Yeah, I think all those patients need to go on a clinical trial. I think they need to be like rebiopsied, making sure you look for reversion mutations. I think there are other agents out there, pol theta inhibitors, PARG inhibitors. So I think they're like, we have to look at other options.
But for people that don't have a million phase 1s like we do, and they have a patient sitting in front of them who's platinum sensitive and didn't progress on a PARP, do you think it's safe? Do you think you're setting them up for worse overall survival? Like, people are kind of want to know. They don't have access to all these things, and
Yeah.
they got to make a decision.
Yeah, I think I agree with Dave, but before I restart someone on a PARP inhibitor, I want to test for reversion mutations.
Agree. Yep. All right, guys, I got to get you to your session with that. Thank you very much. We're over time, so thank you very much. Please fill out your post-test and evaluation for credit, download the slides, and practice age, and you can watch this event online for the next 24 hours and in the coming weeks. Thanks for joining us, and we'll see you around at the meeting.